Welcome to Adapting Class Top 6 OB and Labor and Delivery Medication that you need to know as a nursing student if you are in nursing school and or if you've already finished nursing school and preparing for your NCLEX. These are medications that shows up every time. So stick around. Let's go through these 6 good OB labor and delivery medication. I give you acronyms, mnemonic to be able to understand them. Number one is Pitocin, Oxytocin. How do you remember them? The oxy out to the baby, and oxy, what does it do? Oxygen go down. So that's the way you can remember that. Oxy out the baby, oxygen down. What does it do? Induces or augment labor. That means ensure labor can progress. It can because what? It causes contraction of the uterus. In that process, you can use it in postpartum hemorrhage. If the mommy is bleeding after delivery, you can help it to contract the uterus and make it smaller instead of becoming buggy. What should you monitor for? What? Uterine tachycystole. That means if you give it to the mommy and they're contracting more than 5 contractions in 10 minutes, that is what we call tachycystole. You need to stop it or slow it down. Watch for fetal distress as the baby, as the contraction remain in what? Tachycystole. And this can lead to deceleration. You need to stop the drip. Don't decrease it, don't cut it off, stop it. Usually you need to I give it through IV pump so that you can monitor it. Always monitor fetal heart rate and the contraction pattern so that you can determine if this is a what tachycystole. This medication has a lot of side effects. One of them is ADH-like symptoms. So if I give you Pitocin, it's like I've given you ADH. So you're going to retain your water. You can have edema because of that, and it can also lead to hyponatremia. So you can develop SIDH symptoms. This is why you have to monitor the mommy after delivery because you need to get rid of all the water they've been holding on to. So they usually may have a Foley or they'll try to get them out of bed to pee. But Foley is the best way to prevent them from getting out of bed. The next one is magnesium. What is the mnemonic? Mag makes everything go slow. Mag make everything go slow. What is it used for? Because it make everything go slow. You can use it to depress your central nervous system and it can prevent seizures in the patient who have pre-eclampsia, right? It can also relaxes the uterus in preterm labor. Very, very important. But since it's dropping everything, it can affect every system. Watch for your tendon reflex, deep tendon reflex. It goes down, your respiratory rate goes down, your urine output goes down. How low does you want it to go? If it's a reflexia, is a bad problem. If the respiratory rate is less than 10 and 12, is a problem. If your urine output is less than 25 ml per hour, is a problem. So watch for that. The antidote is calcium gluconate. Every time you give in a patient, what? Magnesium, calcium gluconate should be at the bedside. Therapeutic level is 4 to 7. If it's too high, it's a problem. You always have to have continuous of the fetal monitoring and maternal monitoring to make sure we're progressing. Terbutaline is a turbo for terbutaline. It speeds mommy's heart, right? Because it binds on beta 2 receptors, right? It can do that. But in the process, it also relaxes the uterus. So it's a tocolytic. We use it for preterm labor to stop contraction, slow down the contraction. The nursing notice it causes tachycardia. It's like I'm giving you epinephrine, palpitation, and hyperglycemia in the mother, but it slow down the uterine contraction. What is the problem? If the heart rate is too high, you stop it. Long-term use is a bad problem. These medications, you have to master them. NCLEX love it. Nursing school will ask you for it because those are opiates we use in labor and delivery. but they are different kind of opiate. They are not true antagonists. They can be agonist and antagonist. So they block mu receptors for opioid, and at the same time they can act on it to work. So it tricks the receptors. It can act on it to work or block it totally. It provides a moderate pain for the mother. It can only be given by IM or IV, and the peak effect is usually 30 to 60 minutes. It does not give cause too much sedation, but it can in the mother. That is why you have to time it when you give it to the mommy, right? It can also cause central nervous depression, so you have to know the timing. May be used with epidural in addition, especially in the early and later state. You should avoid in a mother who already uses opiate. Otherwise, it causes withdrawal because it will basically act as an antagonist. That's when it start acting like a withdrawal in this patient. So ask the mommy, have you used drug before? Substance abused. You cannot get Nalbuphine or Butorphanol. Monitor for fetal bradycardia if uh, used in late in labor because it takes a long time to work and it takes a long time to get out of the system and it can cause respiratory depression. What time do you give it to the mommy? You want to give it to at the peak of contraction so that the baby, where there's less blood flow at the peak of contraction, they have less blood medication getting into their system. RhoGAM, right? RhoGAM is Rh negative guardian. It protects Rh negative mother. That's how I call it. Rh negative guardian. It prevents Rh incompatibility in the Rh negative mommy. So we give it to them if they're giving birth to a Rh positive baby. But if they're giving birth to Rh negative, it's not a problem. But if they give birth to Rh positive baby as a Rh negative mother, we have to give you RhoGAM to act as a guardian. You giving at 28 weeks or after you deliver within what 72 hours. Two options. Either 28 weeks or after you deliver within 72 hours. If the mommy is Rh negative, you don't give it to Rh positive mommy. Always. So you got to check the Rh status for the mother all the time. Sometimes we give it prophylactically. That means we give it to you whether you like it or not. If you are Rh negative, right? We're going to give it to you if you have trauma, you have miscarriage, or invasive procedure. Misoprostol is very important because you can use it for what? And it can act like an antacid GI tract problem. But at the same time, it can also be used to soften the cervix and causes uterine contraction. You cannot combine it with Pitocin. It will cause uterine rupture. It ripens the cervix and it can be used in induction, okay? And postpartum hemorrhage causes contraction of the uterus. Things you need to know as a nurse, you can give it through vaginally or rectally. So you can put it in the rectum, it act, or you can give it to the vagina. It can cause tachysystole. So don't give any other medication that causes contraction. If you have previous C-section or you have uterine scar, we will not give it to you because it causes rupture. If you're taking it for antacid and protecting your GI tract for patients who are on NSAID and it will prevent ulcer, we can give this medication to them. Once again, patient taking NSAID who will develop ulcers and they cannot stop taking the NSAID, we give them misoprostol to protect ulcer formation. In this patient, you tell them to have barrier method because if they get pregnant, it can cause abortion. Six medication, OB, labor, delivery, nursing for your nursing school and for your NCLEX. I hope you get the key aspect and mnemonic. If you want to know more, follow the series, subscribe to Adapt NCLEX, and thank you for watching.